Hi, I'm Peter Boland, and welcome back to the podcast, More Health, Less Healthcare. What I'd like to do today is take on a very different topic that we haven't looked at before, and it's called Why Healthcare is Local. All healthcare is local. I want to tell you up front what the series is not. It's not a policy lecture. It's not a partisan gripe session. And it's not another tour through everything that's broken in the American healthcare system, though, fair warning, we're going to look at some of the things that are genuinely broken. What this is a conversation about communities, health systems, health plans, and local organizations. They're doing something different. Places where the conversation has shifted from managing sickness to actually building health. Places where the money is starting to follow the mission instead of the other way around. And this matters to me, that this series isn't designed to catch anyone out. Every hard question I ask because I already know someone who's answered it and answered it well. This isn't a takedown. It's here's what's possible, and here's who's actually doing it. So the title, All Healthcare is Local, it's a provocation, not a slogan. And for 50 years, we've treated healthcare like a national industry. Federal policy, insurance regulation, standardized protocols, as if health was something manufactured uniformly at scale. But health doesn't work that way. It's produced locally in places where people live, work, age, and raise families. Now, medical care accounts for something like 20% of your health outcomes. The other 80% is where you live and what you eat and whether you feel safe and whether you have work. And that's not a controversial claim anymore. It's just where the evidence has finally landed, and the evidence is clear. So if health is local, then accountability for health has to be local too, not just where the hospital sits, but who decides what gets funded, who gets a vote, and who's actually held responsible for whether things get better or not. And here's how we're going to spend our time today. Episode looks at the geography of life and death, why your zip code can predict your better health than your genetics can, and the two hospitals that decided to treat the whole neighborhood as the patient. And episode 2 asks the question that every board member asks next: how do you actually pay for it? And what local has to mean once you get past, let's say, one generous employer, and we'll focus on that in a couple episodes. Episode 3 steps back and asks a bigger question, okay? Compared to what? And we'll look at how the United States actually stacks up against other wealthy countries, and why the story we tell ourselves about being, quote, the best in the world might be the single biggest obstacle to fixing anything. Episode 4 makes the financial case plainly. The sickness economy isn't just inequitable, it's a dead end, even on its own terms. And I'll speak to the moral case and the financial case turn out to be the same case. And episode 4 is one where most people in this industry would rather not talk about out loud: medical debt, what it actually does to people. And this is the part that gets missed: what it does right back to the hospitals and the health plans that generate it. Episode 6 looks at collaboration, how delivery systems and health plans, employers, and community organizations build something together that none of them can build alone. Episode 7 gets into measurement and accountability. And if a community can't measure something, it doesn't control it, no matter how many times it gets consulted. Episode 8 gets structural. What does it actually mean to hand over real decision-making power, not just a seat at the table? Episode 9 names the fiduciary question plainly, and I hope even-handedly. Who actually is responsible for the health of our next generation? And what does good stewardship look like when somebody's doing it right? Episode 10 brings this all together. The health economy we have to build, and why I think we're actually closer to it than most people assume. Every case in this series is real. Real institutions, real numbers, and real outcomes. And some are genuinely inspiring. Now, the honest version of the story is the solutions already exist. What hasn't happened yet, is replication at the scale this deserves. And that's what we're going to talk about. So let's get into it. Episode 1, what I call the geography of life and death, treating the neighborhood as the patient. And here's a fact that stops me every time I say it out loud. In some American cities, life expectancy can vary by more than 20 years between neighborhoods just a few miles apart. The same city, same state, same country, 20 years apart. A Black mother in this country faces 3 to 4 times the risk of dying from pregnancy-related causes as does a white mother. A kid in a low-income zip code gets hospitalized for asthma 10 times the rate of a kid in a more affluent neighborhood across town. And I want to be really clear about something before we go farther. These aren't clinical failures. Nobody's doctor did something wrong. These are geographical failures. And geography is something we can actually change, which is the hopeful part of this. It's not a depressing part. To understand why, it helps to name 2 different economies operating inside American healthcare. The first is what I call the sickness economy. The financial incentives flow towards treating illness, not preventing it. More procedures, more prescriptions, more claims, more revenue. And that's not a conspiracy. Nobody sat in a room and designed it to be cruel. It's just the business model built on the assumption that health is something to be priced and managed after it breaks down, rather than something to be built and sustained beforehand. The result? The U.S. spends more per person on healthcare than any other wealthy country and lands near the bottom of the same group on life expectancy, infant mortality, and chronic disease. In other words, we're paying more and getting less. And the sharpest edge of that gap lands on low-income communities, communities of color, and rural communities that have been shut out of economic opportunity for generations. The second is what I call the health economy. Instead of asking, how do we manage the cost of treating sick people, it asks, how do we create the conditions where people get to stay healthy in the first place? And that requires institutions to act like, what researchers call anchor institutions. Well, that means rooted in, accountable to, and actually investing in the communities around them. But as a strategy, not just as charity. It requires something a lot of big institutions find, generally uncomfortable. Sharing power with communities, not just serving them. And that brings us to the extraction problem. So before we get into what's working, I want to name what we're up against. And honestly, large, consolidated healthcare systems through billing complexity and administrative overhead, and yes, even fraud, end up losing somewhere between half and 3/4 of every healthcare dollar out of the communities that generated it. In many areas, that money goes to a national carrier's overhead, hospital holding company reserves, pharmaceutical supply chains, and billing infrastructure that mostly serves the billing process itself. It doesn't come back to the neighborhood. And the consequences really ripple outward. When health spending spirals, it pulls money away from public education, policing, social services, all the things the community actually needs to be healthy in the first place. Wages stagnate for decades as employers quietly redirect raises into premiums instead. But here's the good news, and it's not a small one. When healthcare dollars do stay local, when a primary care doctor has the time to actually build a relationship with a patient, well, that's a plus, because when a community has some real say over its own health ecosystem, outcomes improve and costs fall. Health is produced locally through housing, food, maternal care, economic stability, even community safety. So the fix isn't just redesigning a benefits package, it's rebuilding accountability for health at the local level, well, where health actually gets created. So let's look at when hospitals actually treat the neighborhood as the patient. And let me show you what this looks like when somebody actually does it. First up, Nationwide Children's Hospital in Columbus, Ohio, put $77 million into the neighborhood around it. Not a new wing, but housing. Their Healthy Neighborhoods, Healthy Families initiative revitalized Columbus's South Side. 224 affordable rental units, 236 homes repaired, 110 homes built or renovated. But housing wasn't the whole story. They wove it together with education, workforce development, and community safety. Hospital employees mentor students every week. A summer career program serves 100 kids. Free tax clinics have returned $4 million to nearly 1,700 families. And the results back up the whole premise. Emergency department visits dropped more than 20%, and inpatient admissions fell by 13%. The neighborhoods they invested in, they hired 1,300 employees from those same neighborhoods, so the economic benefit stayed local too. What Nationwide Children's prove is that affordable housing, done well, functions as health infrastructure, not a nice to have alongside healthcare, but part of the actual treatment, part of the medical treatment, part of the health treatment. Another example is one I'm sure you've heard about, Boston Medical Center. They took a different road to the same idea. And since 2001, Boston Medical Center has run a food as medicine model with 3 different pieces. A preventive food pantry, giving out 1 million pounds of food a year, a rooftop farm growing 5,000 to 7,000 pounds of vegetables a year, and third, a teaching kitchen running 300 free classes a year for 2,000 patients. And at BMC, physicians literally prescribe food based on a patient's chronic condition with the same clinical seriousness as a prescription pad. And food, because food insecurity really travels alone, BMC embedded medical legal partnership attorneys right alongside their clinicians to handle housing instability, utility shutoffs, and benefits eligibility, helping 90% of at-risk seniors keeping their housing. Their tax assistance program has returned more than $8 million to nearly 3,000 hard-pressed families. And the hospital serves immigrant and refugee patients in 250 languages with medical, mental health, and social services woven together. I wanted to stress again, these aren't charity add-ons, they're clinical interventions because they address the local conditions that produce illness before these conditions show up as an expensive hospital stay, even an emergency room visit. So in closing, Nationwide Children's and Boston Medical Center prove something important. Treating the neighborhood as the patient produces real, measurable results. But neither one answers the question every board member asks first. How do I pay for this? And at scale, well, without a $77 a million gift sitting around to draw on. That's exactly where we're headed next. In the episode 2, we're going to talk about finding the money and putting it to much better use going forward. So again, I'm Peter Rowland, and next episode, we're going to talk about finding the money, what local actually means. Thank you for joining us today.